He heads the Atherosclerosis and Lipid Genomic Laboratory, chair the Cardiovascular Genomic Task Force, direct the early atherosclerosis and familial hypercholesterolemia clinics, and is a program director of the Cardiovascular Genomic Fellowship Training Program at Mayo Clinic, Rochester, Minnesota. Dr. Kullo's work on genomic discovery and implementation, particularly in the area of polygenic risk assessment, has been widely cited. He has published more than 400 scientific papers and has mentored nearly 100 medical students, residents, and fellow and junior faculty. Dr. Kullo has been funded by the NIH since 2003 and is a principal investigator in the eMERGE and PRIMATE network of the NHGRI. He was recently awarded the GEMINEA grant by the NHGRI to bring precision medicine to East Africa diaspora population in the USA. He serves on the U.S. National Advisory Council on Human Genomic Research. Dr. Kullo is deeply interested in reducing disparities and equity in genomic medicine. He's working with the undeserved communities to implement genomic medicine program to improve health in these communities. In today's talk, Dr. Kullo will introduce a groundbreaking initiative, the genomic medicine for the individual from East Africa. Despite significant effort like HA3 Africa initiative, East Africa remain underrepresented in genomic research. This region, with its unique demographic history and genetic makeup, holds untapped potential for genomic discoveries. Dr. Iftikhar J. will guide us through the importance of establishing a community-based genomic medicine research program for individuals of East Africa origin. Discover how all genome sequencing can reveal population history, identify disease variants, and pave the way for the development of polygenic risk scores. Please join me in welcoming Dr. Iftikhar J. Please note that we will have a live Q&A session at the end of the webinar. You can ask a question feature to submit your question. Please mute your microphone. Session will be recorded and will be available on our YouTube channel. Dr. Iftikhar, the floor is yours.
Thank you very much for the kind introduction, and very pleased to be talking to you today. So I'll start by sharing my screen.
Go ahead.
Let's see. Can you see my screen?
Yes, it's clear.
Yes.
Okay, very good.
Yes.
Thank you. So thank you for the opportunity to present to you today. Let me start by mentioning that there are major disparities in health, particularly in genomic medicine. And there are many past examples of harms and discrimination, unfortunately, in genomic research. Consequently, the National Human Genome Research Institute's strategic vision, which was published a couple of years ago, has committed to systematic inclusion of underrepresented populations in future NHGRI programs and projects. In addition, the American Society of Human Genetics has emphatically stated that benefits of genomic medicine should be accessible to all people. So with this motivation, we've set out to embark on the GEMINEA project to reduce disparities in genomic medicine in an underserved minority in the United States. Let me start, though, with a brief background of human history and adaptation. As Dobzhansky said, nothing in biology makes sense except in the light of evolution. So if you look at human history, humans evolved in Africa around 300,000 years ago. And then a small group of humans went out of Africa, maybe about 80 to 100,000 years ago, and they rapidly then populated the rest of the world. In this journey, they had to adapt to different climates, altitudes, diets, and pathogens. And one of the ways they adapted was through genomic adaptation and evolutionary changes. So consequently, we see differences in allele frequencies in different continental groups of humans. Another reason for allele frequency differences is a random phenomenon called genetic drift. And a good analogy of this is the drunken man walking across near the railway platform. And he kind of stumbles and wanders through, and eventually he might just be lucky and move to the left and survive, or he might just fall on the tracks and not survive. And so this is also depicted in the right figure, where if you start with an allele frequency randomly of a random variant at 0.5, over many generations, the allele will either fix at 1.0 or will disappear from the population. So these are two factors that drive allele frequency differences in human populations: evolutionary change and a more neutral phenomenon of genetic drift. So with that in mind, we see that polygenic risk scores, which are derived from these common alleles in different continental groups, vary in their performance. And the major reason for the disparity in performance is simple. It is that GWAS datasets, which form the training datasets for PRSs, are predominantly of European origin, nearly 80%, and only about 22% are non-European. Now, this might be changing a bit, but it still remains very similar. So on the right panel, you can see on a principal components plot that the training data from Europeans in blue, you can see the differences in allele frequency, the principal components and clustering in different continental groups in the world. And if you look at accuracy of polygenic risk scores, it kind of declines as the genetic distance with the European group increases. And you can see that the African ancestry individuals typically have the least well-performing polygenic risk scores. This can also be depicted in this continuous fashion, where the accuracy of the polygenic risk score declines. You can see the blue dots representing the European genetic ancestry individuals, and then the green dots representing African ancestry individuals. You can see there's a decline as the genetic distance or increases or genetic similarity decreases from the European group, which is basically the source of the summary stats or statistics that we use to compute polygenic risk scores. And here's an example of a polygenic risk for coronary heart disease. You can see that we've tried several polygenic risk scores. The upper two are what we call restricted, and the lower two are more genome-wide. And if you look at the blue dots, the blue squares, they represent European ancestry. You can see that in all forms, the polygenic risk score for coronary heart disease performs the best in individuals of European ancestry and the least in individuals of African genetic ancestry. And if you just look at the PRS LD-PRED, for example, which is the second from the bottom, you can see that the odds ratio for coronary heart disease were nearly when you were in the upper 5th percentile of this score, but it was only 1.9-fold higher for individuals of African genetic ancestry. And those of Hispanic ethnicity were somewhat in between. So this illustrates this quite dramatic difference in the performance of polygenic risk scores, which are primarily derived from European training data sets, in other genetic ancestry groups, in particular African ancestry groups. So how will we address this disparity? There are really two major ways to do it. One is to just increase the training data sets for different ancestry groups across the world. And the second is to develop novel methodologies that are likely to increase the performance in all human groups, but maybe more so in underrepresented groups of humans. So this is from an article that was recently published in Nature Genetics. It's the perspective, and the next few slides, I'll summarize some of the concepts proposed in this perspective. So to reduce disparities in polygenic risk scores, we can generate new data, but then we should be able to share the data. And then we could deploy novel methods which might improve the performance of polygenic risk scores. Of course, the goal eventually is to hopefully use them to improve human health in the clinic, but we have to consider in the background the ethical, legal, and social implications, as well as the policy, regulation, and funding for such initiatives. So in these next slides, in the bottom panel in gray, I'm listing, what kind of experts might need to be involved, but I'll focus mostly on the top panel, which proposes newer avenues to improve performance of polygenic risk scores. So firstly, generation of new data. This is crucial. There's only so much we can do with method development. In the end, we do need large data sets so that we have summary statistics for different genetic ancestry groups across the world. One way to do this is to establish new biobanks and then genotype or sequence the individuals in these biobanks so that we have genetic data for a larger number of individuals belonging to certain ancestry groups. But by itself, genetic data is not useful. It has to be linked to phenotypes. And typically in the current age, phenotypes are derived from electronic health records. Of course, there are the examples of prospective studies where you can invite individuals to become part of a prospective cohort, and then you phenotype them. But this tends to be very expensive because you have to pay for all the infrastructure to do the phenotyping. So linkage to electronic health records is a attractive option because you can get all the phenotypes in the electronic health record for, let's say in quotation marks, free. It's relatively free. The other thing we need is measures of environment. When we are talking of polygenic risk scores, remember that we are typically the primary intention of using polygenic risk scores at the present is to enhance risk prediction for common diseases. And as you all are aware, common diseases arise from not only genetic factors, but also environmental factors and the interactions between the two. So measures of environment should be collected. These might include at the very basic level, just geolocation, income, education, and so forth. In the United States, currently, there's a lot of emphasis on social determinants of health, and these are being collected in a standard manner now through electronic health records. The last thing is epidemiologic indices. Unless we know the background prevalence and incidence, it will be very difficult to calculate absolute risk with integration of polygenic risk scores. And this is important because when clinicians use risk estimates, they prefer absolute risk rather than relative risk. Once we generate data, we should be able to share it and the most common mode currently, at least in the global north, is to use trusted research environments, also called clouds. This has now become routine, and most institutions and research consortia are using clouds for data sharing and analyses. An important thing to consider is that we should use standards for both phenotype and genotype data in order to maximize the utility of any data that's stored in the cloud. And of course, we need to establish protocols for sharing summary statistics, and more importantly, for individual level data that tends to be more sensitive, and one would need data sharing agreements in place to share such individual level data. As I mentioned, methods development should occur in parallel, and there are many groups working on novel and innovative methods to improve the performance of polygenic risk scores. Examples are listed here on this slide. They include local ancestry mapping, functional annotation, fine mapping. There's a need to increase diversity in reference and imputation panels. Obviously, if you don't have good reference panels, you cannot impute the genotypes from array data. And there's a movement towards using graph genomes instead of the linear HG38 that we currently use as default. And there is data suggesting that if you, for example, use graph genomes instead of a linear reference, you're able to find up to 10% more variation in genomic data from African genetic origin. Finally, we need to address the issue of population structure, even in groups that we think are homogeneous. This was demonstrated in a UK Biobank study of polygenic risk for height, which showed geographical gradients, most likely due to population structure. So if we have improved polygenic risk scores by data generation, sharing, and method development, how do we go on to clinical implementation? Here, the use of implementation science frameworks is very useful, and people can do the implementation in different contexts, social, cultural, geographic. As I mentioned, absolute risk estimates are more useful than relative risk. And communication of risk is not trivial and should consider social and cultural factors, and is a whole science in itself. And then as we implement, we should measure outcomes so that we create an evidence base for clinical utility. As we do all of this, we need to consider what are the ethical, legal, and social implications of implementing polygenic risk scores or data sharing. And these are just some general principles highlighted on this slide. We should respect boundaries that are set by the informed consent. We should respect data sovereignty and participant privacy. There should be opportunities for investigators from low and middle income countries to lead scientific analyses and for participants to share in benefits of research. There may be concerns related to misuse of gender data, genetic data, and including discrimination and stigmatization. And we should use appropriate population descriptors in our reports or presentations. As you might know, the National Academy of Sciences, Engineering, and Medicine in the United States has come up with a report suggesting use of population descriptors in different contexts of research or clinical use. Finally, it's important to consider health policy, regulation, and funding in order to make this happen. Obviously, there's need for global and local funding to build infrastructure and capacity at different sites in low and middle income countries. facilitate storage and analyses on clouds, increase awareness of potential benefits of translational genomics among politicians and policymakers, to encourage investment in genomics. Sometimes these groups are not aware of the potential economic benefits of such investment and research, and increasing their awareness in this regard might be helpful. And finally, we need to limit hurdles to data sharing across borders so that we can all learn from efforts that are being conducted in different places in the world. So in Africa itself, as you're aware, the H3 Africa Biorepositories program was started many years ago and currently includes nearly 24,000 biospecimens from different H3 Africa studies. Other biobanks are listed here: the Uganda Genome Resource and the Non-Communicable Diseases Genetic Heritage Study. And the final one that is about to be launched is the Egyptian Genome Project, where they aim to sequence 100,000 Egyptian adults and 200 ancient Egyptian mummies to provide the first comprehensive genomic data set from Egypt and North Africa. More details about these are in this perspective in Nature Genetics. Now, why East Africa? Now, most of the studies so far, most of the genetic studies at least, have focused on Western, Central, or Southern Africa. And the underrepresentation of East Africa is a major gap in our knowledge. And this region has a unique demographic history, allele frequency spectrum, and likely different linkage disequilibrium patterns. Our focus in Gemini in particular is on the Somalis, who are a distinct population group from the Horn of Africa, and they have a relatively homogeneous ancestry due to endogamy. They rarely marry outside of their group. So actually, I should go back and show you that there's a large diaspora population in Minnesota. This bottom map is of Minnesota, and in particular, Southeast Minnesota, where more than 100,000 Somalis live, possibly the largest collection outside of Somalia. And I happen to work in Southeast Minnesota. That's where Mayo Clinic is. And that's also where the twin cities of Minneapolis and St. Paul are. So these are our three main goals in the Gemini study. We need to engage with the community in order to biobank. We have established a community advisory board where we seek input on informed consent, data sharing, and return of results. And our goal initially is to biobank plasma, DNA, and RNA in about 1,000 individuals. We hope that this is the first step in a much larger cohort assembly. Our second aim is to conduct population genetics analyses and construct polygenic risk scores. We'll be performing a 30x whole genome sequencing and calling variants using graph genomes. We'll look at population structure and mixture and signals of selection, and then compute polygenic risk scores initially for quantitative traits such as lipids, height, and BMI. We also, in the last aim, are intending to identify and return actionable results from whole genome sequencing. As you know, there's a list of genes that has been created by the American College of Medical Genetics. And actionable pathogenic variants in these genes are thought to be actionable and should be considered for return in research studies. So we will do that. And we might also return certain pharmacogenomic variants. And we do intend to assess near-term outcomes as well as psychosocial effects. I just, in the next couple of slides, want to give you an idea of the challenges in community engagement and how we have attempted to address these. So the Somali community has multiple clans and subclans, and clan leaders have influence on decision-making. There's a huge influence of religion, and the majority of Somali people are Sunni Muslims, And imams or religious leaders are very influential in the community, and faith guides decision making. One needs to consider cultural factors. The community is very family oriented, and they typically gather in community centers, mosques, and restaurants, and they have unique perceptions related to health and disease management. Social determinants of health play an important role. Unfortunately, many individuals are low income. They have low literacy rate, particularly among the older members of the community who immigrated to the United States. They have challenges in accessing healthcare and insurance, and they often are not able to speak in English, and therefore there are cultural and language barriers. There are several community-based organizations that are influential, and I'll go that in the next slide. So one of the initial things we wanted to do was to identify key stakeholders in this community. So there are physicians, nurses, and research study coordinators from this community working at Mayo Clinic, for example, or Hennepin County Medical Center in the Twin Cities. So we have been in touch with these individuals. The institution, say, for example, Mayo does have core facilities to engage with minority and health disparity groups. These include research recruitment services, research shared services, and a Center for Health Equity and Community Engagement Research. So these are groups that we can engage with to help us in turn engage with the community. There are community-based organizations, and these are listed here. There's a Somali Health Advisory Council, Pamoja Women, which promotes breast cancer screening in women, Partnership for Health and Wellness, Rochester Healthy Community Partnership, and Somali American Social Service Association. And then the leaders in the community are imams or pastors, members of the Somali business community, social workers, and community elders. So we've been working with these key stakeholders as we prepare for the genomic medicine implementation project. And this is just a timeline of what we've done so far. We started by conducting a literature review focused on research conducted within the Somali community, met with Mayo Clinic researchers and clinicians experienced in research within the Somali community, developed a framework to contact Somali community-based organizations and key individuals, held multiple meetings with key stakeholders to gain insights on engaging with the Somali community, engaged with religious leaders to obtain support for the research study, and initiated a process to we've hired two study coordinators now from the Somali community, and continue to seek input from the Community Advisory Board, which is nearly 16 Somali individuals from Southeast Minnesota. And we are developing recruitment materials both in English and Somali languages. One of the documents that we have sought input from the Community Advisory Board is the informed consent document. The highlights of this document are that as for a typical biobanking project, it requests permission from the participant to use DNA for broad genomic research and not limited to a particular trait or disease, and then whether they would be interested in return of actionable results or whether they're interested in blocking certain categories of results. There is an expectation that such data should be shared for public good, and that is also highlighted in the informed consent document. And there is also a mention of recontact, so that if we want to recontact a participant, for example, for a clinical trial based on their genotype, or then we would have permission from the participant to do that. And so these are some elements of the informed consent document that we have sought feedback from the Community Advisory Board. So these are the two sites that we are recruiting from. First is Mayo Clinic, Rochester, Minnesota. And then the other is the Hennepin County Medical Center, Minneapolis, which is about an hour and 15 or 30 minutes north of Rochester. This happens to be the largest safety net hospital in Minnesota, and it serves Somali and other East African communities. And these are just shown on the map here, their location. This is a map of Minnesota, which is an upper Midwest state bordering with Canada. So what do we intend to do in this study? We will biobank, obviously, we'll collect plasma, DNA, and RNA. We want to administer surveys that are focused on lifestyle factors, family history, ethno-linguistic origin, risk factors for cardiovascular disease, any history of prevalent disease such as diabetes or cancer or coronary heart disease. We do have domains that assess social determinants of health, including education, income, and any perceived racism that people might be encountering. Then both medical centers where we are recruiting from uses EPIC, which is a form of an electronic health record, and then we will perform whole genome sequencing to 30x in these individuals. We will be doing population genetic analyses. In particular, we are very interested in inferring the demographic history of the cohort and get an idea of historical population movements. We want to assess the degree of admixture. As you know, the Somalis are straddle the border between Africa and Middle East, and there's a lot of historical migration, trade, and mixing that has occurred. So these individuals are admixed. We want to look at global ancestry sites, frequency spectrum, and LD patterns, and identify any signals of selection that might have resulted from unique exposure to, say, dietary patterns, pathogens, or climatic changes. And then we will attempt to do local ancestry inference once we have available relevant reference panels for the source populations. As I mentioned, we do aim to develop polygenic risk scores for relatively accessible quantitative traits, lipid levels, height, and BMI, which we assume will be available on most of the participants. And we will account for ancestry, admixture, and population substructure as we develop these polygenic risk scores. We will not be returning polygenic risk scores because we don't have any validation groups, and we are not sure what the strength of the polygenic risk scores would be for diseases of interest. However, we do aim to return, as I mentioned, pathogenic variants from the ACMG list of genes. We will obviously annotate these variants and then inform the participant that there is a result that might be of relevance, medical relevance, and then a genetic counselor will convey the results to the participants. And these results will be placed in the electronic health record, and the participant will be encouraged to seek additional treatment management through their primary care provider. We will also convey actionable pharmacogenomic variants to individuals so that these could be useful in the drugs they're receiving. We aim to look at near-term outcomes, such as a referral to a new specialist, new tests that were ordered as a result of the return of results, any surveillance that was initiated, for example, colonoscopy for colon cancer or breast MRI, breast cancer, or lipid profile for familial hypercholesterolemia. We will look at intermediate outcomes, and these include a new test finding, a new diagnosis that was made, or cascade testing measures that were initiated to test first-degree family relatives. Then we'll look at clinical outcomes. Did anybody have a risk reduction surgery, for example, mastectomy, or was a new medications or therapy started or altered? Was, for example, lipid lowering medication started or the dose was increased? So the investigators are listed on the left, and then we do have a community advisory board. We are also fortunate to have a scientific advisory board that includes several individuals from Africa, including Professor Michelle Ramsey, Dr. Ananya Chaudhry, and Professor M.A. Lumaka. And we have colleagues in the United States to help us with graft genomes and variant curation. So I want to end here and acknowledge the many individuals that are contributing to this work. And I'm grateful for the funding agencies, particularly the NHGRI, which funds the GEMINEA grant through this Advances in Genomic Medicine Research grant listed here. So I appreciate your attention and would be happy to take questions. Thank you.
Thank you, Dr. Iftikhar, for the insightful presentation. And we will now open the floor for the questions from our audience. If you have any question, please use the raise hand feature, type your question in the QA box. We can. Yes. Who have the question, please? Please raise your hand if you want any question.
Hello, Dr. Iftikhar. Thank you very much for your presentation. I am Wafa Rashid from Egypt. I would like to ask a question regarding what are the expected near-term outcomes for participants receiving the actionable results, and how does GEMINEA plan to track these outcomes over time?
Yes, so the grant funding typically is 4 to 5 years in the United States. So I think the first year would be community engagement, the second year would be recruitment, and the third year would be return of results. And that leaves us years 4 and 5 to track outcomes. And so we obviously, at this point, will not be able to comment on long-term outcomes, but certainly the short-term outcomes would be very simple. For example, what % of people have actionable variants? That's also a challenge because identifying pathogenic variants in a group that's understudied is not easy. And in fact, there have been reports from previous whole genome studies by Dr. Ananya Chaudhry showing that there may be novel variants present in African populations, and also the reverse, that the ACMG genes may not be entirely, the list may not be entirely relevant. So, but in any case, we will, compute the number of people with actionable variants. Typically in the US, if you take the ACMG list, it's super 3 to 5%. We'll have to see what it will be in this group. And then we will see, we'll see process, intermediate, and clinical outcomes that occur once these results are returned in the clinical setting to the patient and their providers. What are the new diagnoses that are made? What are new tests that are ordered? What actions are taken based on that test? So I will give an example. Let's say a patient has a familial hypercholesterolemia variant. Then what is the test that's ordered? Is a lipid profile checked? If it had been previously checked, does the provider go back and say, oh yeah, this was increased and maybe due to familial hypercholesterolemia? Is lipid medication started? Is coronary testing done? Screening, for example, coronary calcification or stress testing. And then is a new medication started, for example, a statin. So that's just an example of the kind of outcomes we should be able to assess in the time frame of the funding of this grant.
Thank you so much. Please allow me to ask another question regarding, could you explain the choice to use grad genome reference based on African sequences from the Pan-Genome Consortium rather than the traditional one of GRCT38, and how this limited variant scoring in East African populations?
You're a little bit faint, but I think the question is the reference panels. Yeah, I think that ideally the reference panels should be from within the population. As you know, typically reference panels include a combination of 1,000 genomes and Human Genome Diversity Project. There is a ongoing effort funded by the National Human Genome Research Institute called the Human Pan-Genome Project. And as part of that, they are planning to do a T2T, very extensive whole genome sequencing of 350 individuals in their first phase. And a significant proportion of those would be African genetic ancestry individuals. So we will work with the Human Pan-Genome Initiative and see if we can leverage some of that pan-genome data to create a reference panel. But short of that, we might use whole genome sequences from regions that are in East or have been collected in people from East Africa or from neighboring countries as a backup. And then the last, but not the ideal solution, would be to use 1,000 genomes plus HGTP.
Okay, thank you. We have question from the Dr. Oscar from the Kenya. He said, beyond Somali ethnicity, are there plans to work with other ethnicity in the East Africa or to recruit in the East Africa? I would be interested in such question.
Yeah, we are not limiting to Somalis. They just happen to be the most, prevalent in this region. But there are other representatives of East Africa, for example, Ethiopia or even Kenya. And so we're not necessarily restricting to just Somalis. It's just that numerically, they're more likely to be in the study. We are constrained by funding, and we hope that this is an initial step towards a much bigger biobank of individuals from East Africa, where we hope to include even people from Ethiopia, Sudan, Kenya. As far as recruiting in East Africa, we hope eventually that we are able to do that. As you know, conditions, unfortunately, are a bit unstable in certain countries, making it difficult. But that's something we have in mind as we look to, the next stage of an expansion of this biobanking effort, that we might even collaborate with investigators on the ground in those countries. But for now, we are working with the diaspora population in the United States. And, we're pretty much open to any country in East Africa and not necessarily just individuals of Somali origin.
Another question, Dr. Iftikhar. In light of global concern regarding genetic data privacy and sovereignty, how are you addressing issue of data control and participant autonomy, particularly with regard to future secondary uses of the biobank samples?
Yeah, I think that's a very sensitive topic. I think it is dependent on the context as well, whether you're working locally in that country, or whether you're working with the diaspora populations in another country. We are, being in the US, we are working with the diaspora population. And we are working really hard to engage with the community so that they're aware of the potential benefits to the community. They're prone to different diseases. They have different healthcare issues than other communities. And if we don't engage them in precision medicine, then they'll be left behind, because a lot of medicine will be precision medicine. It'll be based on genomic data. There are already many centers in the US that are doing screening for the ACMG genes or tier 1 genes, particularly the tier 1 conditions being breast cancer, colon cancer, familial hypercholesterolemia. And we need to include underserved communities in those initiatives, otherwise we'll just widen healthcare disparities. There are many nuances here. So the funding institution does want data to be shared. And in the grant, we mentioned that we would like to share that data, but it will be after consultation with the community. So I think we will need to continue that conversation with the community as to what that means. Obviously, I think the scientific world would benefit from data sharing, and that would be our intention, but we'll do that in consultation with the community. There are privacy protections in place, which we'll absolutely follow. And then there's a question of benefit sharing, which I don't think is fully resolved. For example, if you take the hypothetical situation where some unique genetic variant is found and that identifies a new pathway and potentially a new drug, if the benefits accrue from that discovery, should those go back to the community? So that has been brought up. And again, this is something we will, as I said, continue the conversation with the community as to how that might evolve. So I hope I have answered the points that you raised.
Dr. Iftikhar, I think that we have another last question, if you don't mind. Would you consider accepting?
I can't hear you very well. Please, could you speak up a little bit?
Okay. We have another question, if you don't mind. Lawrence, would you consider accepting FFP tissue from the breast cancer patient from Uganda?
I'm sorry, I can't really hear you. Is it in the chat?
Yes, it's in the chat. It's from Lawrence. He asked about would you consider accepting formalin-fixed paraffin embedded tissues from breast cancer patients from Uganda? These are for a PhD project.
Yeah, that's a good question. I think that one can extract DNA from formalin-fixed tissue. However, since it's from a breast cancer source, we would generally want to avoid cancer tissue. We want to focus on germline tissue. But it seems to be a very unique resource. And I'm sure, there'll be scientific questions that can be answered with the help of this tissue. But I think for this particular project, we will want to focus on germline tissue. And as you know, with cancer tissue, there'll be unique mutations and somatic changes that might interfere with our analyses that is focused on germline tissue. As far as the age, no, the age is not an issue. We are going to enroll anybody who is an adult, anybody greater than 18. So there's no limit to age. The people we cannot accept are people who had a bone marrow transplantation, because as you know, their genome then is that of the donor.
I think we don't have any. Okay, Andre Otawan, go ahead, ask your question. Mr. Andre, you have question? Go ahead, ask your question. Okay, Andre, go ahead.
We
Hello?
cannot hear you, Andre.
Andre, we can't hear you, Andre. You can, please ask your question. Okay, I think we have problem with the patient phone. Okay, thank you again, Dr. Iftikhar, for answering the question and for your excellent presentation. It was a pleasure to have you with us. Thank you, all of attending. Thank you very much, and thank you for all attending, and hope you will find it informative and enjoyable. Have a great day.
Thank you. Bye now.
Thank you, Dr. Iftikhar.
You're welcome.
Bye-bye.
Thank you.
Have a good day. Bye-bye.
Bye bye.